My name is Thor Halfdanarson, and I'm a professor of oncology at Mayo Clinic in Rochester, Minnesota. I would like to thank the organizers of this meeting to give me the opportunity to speak on cumulative treatment toxicities in neuroendocrine tumor therapy. These are my disclosures. So, neuroendocrine tumor therapy is very effective, and all treatments have some side effects. So we need to balance the needs of the patient against the burden of the side effects. So essentially, try to weigh the benefits of the treatment and weigh the risks and side effects, and do some calculations in our mind to see if certain treatment is worth the risk. Thankfully, for neuroendocrine tumors, that is typically a fairly easy thing to do. So the side effects are typically associated with the dose of the drug and how long it is given. And so if you're on a higher dose and you take it for a longer time, you may have more side effects. And thankfully, permanent and serious side effects of neuroendocrine tumor therapy are fairly uncommon, but milder side effects certainly are not. So I find it helpful when we go through side effects of NET therapy to look at the different treatment types. So we can group NET treatments into several main groups, and you can see them there below. So we can target the somatostatin receptor either with somatostatin analogs or with PRRT. We have what we call targeted therapy with kinase inhibitors and mTOR inhibitors and even immunotherapy. And then we have old school chemotherapy, which still has some value in patients with neuroendocrine tumors. And then surgery and radiation treatment. But just because radiation treatment is so uncommonly used, I decided to leave that out of today's talk. So let's get right into it. Let's start with somatostatin analog therapy. So very well tolerated, but certainly not free of side effects. So the common somatostatin analogs we use in the clinic would be octreotide and lanreotide, and these really truly are the workhorse in the NET clinic, at least for well-differentiated neuroendocrine tumors with expression of somatostatin receptors, especially if these are functional tumors. Exceptionally safe drugs, even if you use them for prolonged time in terms of long-term serious complications. They are really, really safe, but certainly not free of side effects. And these side effects are typically reversible. So once you stop the drug, the side effects go away, and they can be treated adequately by using supportive medications. I'll go into that a little bit, or by reducing the dose, or if needed, which is not very common, just by discontinuing or stopping the treatment. So let's introduce you to the pancreas. So, and because that's the organ that probably is most often affected sort of clinically. So the pancreas has a lot of different jobs, but the jobs that we interrupt with somatostatin analog therapy are the production and the release of digestive enzymes. So when we eat, the pancreas pumps out these digestive enzymes that help us digest the food. And then it makes insulin. And the insulin, of course, is critical in adjusting or managing the blood sugars. So first, with the digestive system in general. So the somatostatin analogs have very complex effects on the digestive system. We don't have time to go into all of that. But for this talk, what we will be talking about is the ability of the SSAs to decrease the ability of the pancreas to release digestive enzymes. So normally when you and I eat, the pancreas senses that and it squirts out these digestive enzymes that help us break down the food, the fat, protein, and carbohydrates. And if you don't release enough of these enzymes, then you won't be digesting your food properly. And what we're most interested in, at least in this context, is the ability to digest fat. So if you can't digest fat, you will have a condition called steatorrhea, which essentially means fat in your stools. So this is because of increased amounts of undigested fat in the stools. So you can have bloating, cramping, flatulence, light-colored, greasy, loose, and often very malodorous stools that often float in the toilet bowl. I'm sorry for being so graphic, but this is just what it is. And there might be an oil slick on the water in the toilet bowl. And this is something that the patients are often very sort of distraught by, and this may affect other family members and coworkers. And this is just one of those things that patients don't really want to talk about. And if you let this go and you don't do anything about it, this can, in some cases, lead to vitamin deficiencies over time, especially fat-soluble vitamins. But that will typically take some time, probably years. So how do we deal with this? How do we diagnose it, and how do we manage it? So the key is to start by talking about it. And this is probably the thing that people don't want to talk about in the clinic, but this is something that we neuroendocrine providers need to hear about. So in patients who are on a somatostatin analog and have noticed these changes in their bowel habits after starting the SSAs, you may not need any testing. So you have the right patient on the right drug with the right symptoms. That's probably all you need to diagnose it. We don't have to go to any expensive testing. So you can try treating it and see what happens. Sometimes there might be more than one diarrhea going on, and that's where it might be good to get some testing done. But now we're just talking about something that started after you started the somatostatin analogs and sounds and looks like steatorrhea. So we can collect stool if we want and measure fat over the course of 2 days on high fat diet, but that's a pretty unpleasant test for everyone involved. Or we can just go ahead and treat. So we can try over-the-counter digestive enzymes. It has to say enzymes on it, not probiotics. It has to be enzymes. Or we have to go to prescription strength enzymes like Creon or Zenpep or Biocase. Those things are often needed. They tend to be sometimes expensive, and not all insurance plans have a good coverage for those. But the key is that whatever it is, be it prescription strength enzyme or over the counter, you have to take this with the food. It has to go down with the food, mix in with the food, and help digest the food. If you take it an hour before or an hour later, it won't help. And then we may have to titrate or increase or even decrease the dose to sort of dial in on controlling the symptoms. And some people may need a little bit of this, and not with all meals. Others may need more, and with most meals. So we sort of have to try a number of different things, figure out what works for that individual patient. So what about the other complications of somatostatin analogs or SSAs? Well, they can cause gallstones, and they are actually quite common in patients on somatostatin analog therapy, and often asymptomatic. So, for example, there was a study from Italy that looked at a large group of patients with neuroendocrine tumors, and 27% of them developed system stones or gallstones, not necessarily always in the gallbladder, somewhere in the biliary system. And among those 27%, almost a third had complications from the gallstone. So a gallstone getting stuck in a bile duct, a gallstone causing pancreatitis or some other unpleasant things. And we can really reduce the risk of complications by removing the gallbladder. And that's why many surgeons elect to remove the gallbladder at the time of the cancer surgery. And on the picture here to the right, we can see right in the middle there, the thing that's filled with like little bright things like a cluster of stars. So these are small gallstones in the gallbladder. I don't think this patient was in an SSA, but I just found a very illustrative picture. Well, moving on. So SSAs can also affect your blood sugar. So because indeed they can decrease the production and release of insulin from the pancreas. And this is actually pretty common. So, but we didn't really know how common this was. So this year, there was a study of more than 200 patients from England, and 19 of these 200 patients developed a new type 2 diabetes after starting the drugs. Well, some of them might have developed that anyway. We can say type 2 diabetes is a pretty common condition. And of those who had type 2 diabetes going into the treatment, many of them actually had worse blood sugar control. So, and if we leave blood sugar uncontrolled, high blood sugars, that over time can cause a number of problems. Usually it takes years. So kidney damage, neuropathy, and some other unpleasant complications. And now that we're on the endocrine system, thyroid dysfunction, mostly hypothyroidism or lazy thyroid, has been reported in patients on somatostatin analogs. But it's pretty uncommon. I've looked for it often, and usually I don't find it. So we can also target the somatostatin receptor with PRRT. So most of you are probably fairly familiar with PRRT or peptide receptor radionuclide therapy. So essentially delivering a small charge of radiation directly to the tumor cells through the somatostatin receptor. So PRT is truly a game changer in neurotumor therapy. So we didn't really have effective therapy for patients who had progressive tumors and somatostatin analogs, and then we got PRT, and it really has changed things. So complete responses, as you may know, are fairly uncommon. I'd say pretty rare. I have seen one or two in my career, but many patients have what we call partial responses, where there's a little bit of shrinkage, and others will have stable disease for a long time. And that long time can sometimes be years. And there are some data recently that have suggested that patients may even live in excess of 10 years if they receive PRT at some course in their illness. So if a patient is expected to live that long, obviously you will have more time to develop side effects. So that's why it becomes really important to talk about the risk. So I inform all of my patients about the risks of PRT, about the other treatments that we could use instead, and then we have to make sort of an informed decision whether PRT is something we would like to proceed with at this point in time or find some other treatments. But I will say that among the treatments we have after progression on somatostatin analogs, there is really nothing that's more effective than PRT, at least not at the current time. So the PRT it's radioactive, so it's given IV, so it goes everywhere. So this will affect your bone marrow. And in most patients, this radiation exposure to the bone marrow is pretty minimal, and nothing really comes of it. So little clinical consequence. Sometimes there is some lowering of the blood counts, especially the platelets and the white blood cells, but sometimes also of the red blood cells or the hemoglobin. But that typically recovers over time, but sometimes we actually have to stop the PRT prematurely. There have been patients I've had where we wanted to give 4 cycles of PRT, but we're only able to give 3 because the blood counts were just too low and took a long time for them to come up. Despite the low blood counts, bleeding and infections are, fortunately, I'd like to say, are thankfully very rare. So what about the really severe complications? They do exist. So a PRT can cause leukemia, acute myeloid leukemia, or a condition called myelodysplastic syndrome, or MDS. So MDS is not really leukemia, but often quickly turns into leukemia, and is not quite as severe and life-threatening as acute leukemia is, but it comes pretty close. So this may happen in up to 2 to 3% of patients treated with PRT. But if you sort of look at that the other way, so of every 100 patients treated, less than 3 will develop leukemia or MDS, or 97% of those 100 patients will not get leukemia. So we have to look at the bright side as well. So the risk may be increased in patients who received chemotherapy or radiation therapy in the past for the neuroendocrine tumors or for other cancers. And there's really no good way of predicting this. And once it happens, life expectancy is short, and the current treatments are very ineffective. But we're getting some promising drugs that may help some patients in this condition. So moving on to other complications of PRT. So most of them are reversible and transient. There can be their bowel obstruction has been reported and often is transient. Some bone worsening of bone pain in patients with a lot of bone pain, and some disturbance of the immune system, the pituitary gland function. Typically, nothing that lasts for a long time. So move on to targeted therapy. Well, the interesting thing about targeted therapy, it is actually not that targeted. We call it targeted therapy, but it actually hits a lot of normal tissue as well. So we have 3 different types. So the kinase inhibitors are probably among the more commonly used targeted therapy in neuroendocrine tumors. So this is a family of drugs that targets the different components of the very complex cancer cell machinery, but they're thought to affect the blood flow more than anything else. And here we have some examples: sunitinib, cabozantinib, surufatinib, lenvatinib, axitinib, and there are some others. These are the IPs, end with an IP. So the side effects tend to be transient and manageable, but can be pretty severe, and we often have to reduce the doses or sometimes even stop the drug. I would say hypertension or high blood pressure is probably one of the more common side effects, and this can occasionally result in severe complications like strokes, heart attacks, and even bleeding into the brain. So we have to be really careful with this and monitor and treat very aggressively. Lots of other side effects: skin toxicity like hand-foot syndrome, like red and tender hands and feet, fatigue, diarrhea, and some other things. But by and large, if you follow patients very carefully and if you address these side effects early on, most patients are able to stay on these drugs, but sometimes at a lower dose. So the next one is from the family of mTOR inhibitors. That's really only everolimus. There are some other mTOR inhibitors that we have, but everolimus is the only one approved for neuroendocrine tumors. And it actually works for a lot of them, for the lung neuroendocrine tumors, for pancreatic neuroendocrine tumors, and for small bowel neuroendocrine tumors that are not associated with the carcinoid syndrome. As with the kinase inhibitors, there are definitely multiple side effects and mouth sores that typically respond to dose reduction, or sometimes we have to use a steroid mouthwash. These can raise the blood sugars, especially if given with somatostatin analogs, raise the triglycerides, which can, in rare cases, cause problems like pancreatitis, and then there are some other less side effects like skin rash and infection. But as with the kinase inhibitor, most patients can actually stay on this with some dose modifications or adjustments. Sometimes you have to stop for a little bit and get started again at a lower dose. Immunotherapy is kind of a targeted therapy, but not really. So the immune checkpoint inhibitors or immunotherapy or ICIs, these are drugs that release the natural brakes of the immune system. So the immune system is held in check by these what are called natural brakes, because otherwise it would just run amok and attack pretty much everything it saw in the body, and that would be called an autoimmune disease. So these drugs, they make the immune system more aggressive. They rev it up, and now the revved up immune system is ready to go find and kill cancer cells. But unfortunately, it can also kill some normal cells in the body. So immunotherapy is mostly used for poorly differentiated neuroendocrine carcinomas, and not so much for neuroendocrine tumors, where it doesn't really work that well. But this revved up immune system can start attacking normal cells in the body, and such as the skin, the thyroid, lungs, digestive tract. So these are all things that we have to look out for very carefully and treat very, very aggressively. But this can really happen to any organ in the body. So these would be called autoimmune complications. They can be anything from mild skin rash that maybe only needs a moisturizing cream or a little bit of steroid cream, to very devastating inflammation of the heart and the nervous system, and even occasionally to deaths. So if you compare immunotherapy to chemo in general, it tends to have milder side effects, but when they happen, they can be really, really severe. But thankfully, that is not that common. So be very vigilant if you're on immunotherapy. Any new symptoms, ask your provider. There are no dumb questions when you're on immunotherapy. So if there's a new symptom you're worried about, you ask. And it's so critical if there are complications to intervene early, use therapy as needed with steroids or whatnot. So chemotherapy, we don't use a whole lot for pancreatic or for neuroendocrine tumors in general, except for pancreatic and lung. That's where we use capecitabine and temozolomide or CAPTEM. CAPTEM is actually exceptionally safe. It can lower your blood count and occasionally result in infections, but it's a really, really safe chemotherapy. Other chemotherapies, especially those that have oxaliplatin, like FOLFOX and CAPOX, these can cause debilitating neuropathy over time, and this is the oxaliplatin that does that. Nerve damage that results in numbness and tingling, and that may not even get better if you stop it. There's a low risk of chemotherapy causing leukemia, and for most patients with high-grade neuroendocrine carcinoma, that is not of any concern, because, well, we're dealing with a very lethal, aggressive malignancy, and we just have to use chemotherapy. So this is still the cornerstone for poorly differentiated neuroendocrine carcinoma therapy. So lastly, I just wanted to mention surgery. Although I'm not a surgeon, I'm a medical oncologist, I have to deal with a lot of consequences of surgery. So if you remove a piece of the small bowel, you can have some complications from that. Now you may not absorb vitamins as you did before. You can run into B12 deficiency. I actually saw that today in the clinic. Someone who had the small bowel resection a few years ago and now has vitamin B12 deficiency. Other vitamins, especially if there are long segments of the small bowel. And then we have what's called bile acid diarrhea. So if you've removed a big chunk or even a small portion of the small bowel, especially towards the far end as you get closer to the colon, what's called the ileum, you may no longer absorb bile acids or bile coming from the liver. And now the bile ends up in the colon, where it works as a powerful laxative. So you can have diarrhea, often with urgency, and occasionally incontinence. And just before I came on this presentation here, I actually saw a patient today in a video consultation who has classic bile acid diarrhea. And you can treat this with what's called bile acid binding drugs like cholestyramine and cholestyramine. And then with major pancreatic resections, you can also get pancreatic exocrine insufficiency, as you would get with somatostatin analog therapy with steatorrhea. So just to summarize this, so side effects of NET therapy are common, but generally reversible and often mild. So they can be managed with supportive measures and sometimes dose reduction, or even occasionally by stopping the drug. So cumulative side effects that sort of build up over time, thankfully, are not that common. And the different drug classes, different types of therapy have their different sort of unique side effects. So you really need to know what the patient is on when they present with these symptoms. But the most concerning side effect from therapy is the treatment-related myeloid neoplasm, with the acute leukemia, or the MDS from PRRT. But thankfully, this is fairly uncommon. So that brings me to the end of my presentation. Again, I would like to thank the organizers for inviting me to speak. Thank you.